So Professor Dunbringer is pediatric endocrinologist in the University of Antwerp, and she, of course, built the slides, and it was the topic was to discuss about the rise of the incidence of type 1 diabetes. So type 1 diabetes is regarded as an epidemic. We talk a lot about epidemic since several years. We speak, of course, about COVID, obesity, but type 1 diabetes is also something that is more and more important in our societies. And it is not more important because we have more registries. It is important everywhere where there are registries. Of course, you have to know that most registries regarding diabetes are based on a voluntary basis. It means that doctors have to introduce the numbers. But still, if we can say that there is a rise of 3.5% per year of the incidence of type 1 diabetes. So the maps are telling this better than the numbers, I think. Of course, here the color codes are different in those maps, but what we can see is that in less than 20 years, if we look at, for example, the northern countries in America, we can definitely see, I think easily, that the incidence of type 1 is rising. But it is also true in less developed countries, for example, in Africa. And we can say that several companies invest also in the registries there in Africa to know a little bit more of the rise of type 1 diabetes. What we can say is that it's not all in the global numbers, it's also in the ages. So we have a rise of incidence of type 1 diabetes, but it's concerning also the younger patients. So we see more and more of those young kids in our clinics. The question here is why? If we would have an answer to that, we would be very happy. But still, we will try to cover it. Okay. So how is this working at all? We knew a little bit of this, and we will cover it a little bit today. So in the normal pancreas, you have insulin, and insulin is targeting tissues with a receptor, and that helps glucose, as we say, moving inside the cells, but it helps glucose to be metabolized, which is the most important thing. And in type 1 diabetes, there is a defect in the beta cells that are not able to secrete enough insulin. And this defect is caused by a destruction of the cells, which is based on dysregulation of the immune system, perhaps a little bit of autoimmunity, perhaps a little bit of inflammation, and perhaps also the cells, they lose their identity. And of course, because you don't have enough insulin, then there is high blood glucose in the body. So what do we know about the development of type 1? We know that there is a genetic risk in the population, and it is the same genetic risk as for allergy, for example. You have the risk, but then to have the disease, you need something else. And something else is a trigger in the environment somewhere. And this trigger is causing an immune reaction. And what we can measure in clinics about this immune reaction are the antibodies targeted against the beta cells. That is all what we can do. Of course, in research it's different, but in clinics, that is the marker of type 1. And then you have several stages of the diseases. I will not go in details about these stages, but what I can say is that previously we were saying you can be autoantibody positive, or you can have the disease. Now we say that there is a stage in between when there is this regulation of the glucose homeostasis. So there are several stages as well as in type 2 diabetes. So what about the risk for developing type 1 diabetes? We have this genetic risk that is explained in 50% by the HLA types, as it is for celiac disease or arthritis, for example. It's not typical of type 1. So HLA profile explains half of the risk. And if we go in this genetic risk, we know that there are polymorphisms that also explain the risk. It's always polymorphisms explaining a stronger attack to the beta cells. Why the HLA? Because this is how the antigens are presented. So this is the system that presents the antigens to the lymphocytes, the smart lymphocytes, which are the T4 lymphocytes, CD4. And if you have certain types of HLA, you will present better certain types of antigens. And there are antigens that induce a little bit more the autoimmune attack. So this is how we can understand that. Of course, how does that develop? You can have tolerance against the autoimmune disease, and you can lose this tolerance, because normally in the thymus, you are supposed to delete all those autoreactive lymphocytes. But here you lose this tolerance somehow. So what we can say about these HLAs that are at risk? We have two types of HLAs. We have several, but the strongest ones are the DR3, DR4. You all know about this. What we can say is that there is a trend in the last decades of an increase of the less at-risk HLAs subtypes. So it means that if we look at HLAs as a risk, we have more and more of the subtypes that do not confer a high risk. So we believe that there is an important role for environmental factors, the triggers that help type 1 diabetes develop. And as said, it develops in the early stages. And in the early stages, we can evaluate the antibodies at play. And there are some antibodies against beta cells that are more an expression of a heavy disease. This is a little bit a controversial field, but we can say that some of these antibodies will tell the patient is very prone to develop type 1 diabetes. If we look at first-degree relatives of the children that have a brother or sister, parents with type 1, they develop antibodies against the beta cells, but also against other tissues as well, and you have some sort of a kinetics. And the kinetics is going down according to age. So the earlier we look at it, the higher the titers will be. This is, of course, linked to the way the immune system evolves, but it is also according to the way the pancreas is working. So what we can say is that islet autoimmunity is developed very early on, and it declines with age. And there is some sort of a fertile period in life that you can trigger the autoimmune against your pancreas. What we can say also is that in the early ages, the pancreatic islets are working very hard because the blood glucose level, the fasting one, is quite low. So we believe that this high demand and this high level of working by the beta cells stimulates the presentation of antigens and the autoimmune attack. What about those environmental clues? We always think about type 1 as a part of genetics and environment, but it is true for all disease as well. If you have a patient in your hospitalization ward that has a pneumocoque and a pneumonia with pneumocoque, why this child has a very heavy infection and his classmate doesn't have it? Because of genetic and also because of environment. It's true for every disease. So here, what are the environmental clues? Of course, infections. Of course, also infections that target the gut. So we know that some viruses have an affinity for beta cells. We can find particles of those viruses in the beta cells. And of course, there is the global exposure to food. And food modifies the microbiota. And the function of microbiota also modifies the inflammatory environment that can be general, but also the way we balance our immune system. So this microbiota is influencing the balance with the cells that regulate the autoimmunity, which are the Tregs. So we can definitely conclude that that is a very important system in the environment. So how is it working? We have a propensity for autoimmune attack, and we have several hits. So we don't have to think about type 1 diabetes as being a genetic risk and then something happens. There are several something that happen that cause type 1 diabetes. It can be infection, it can be psychological stress also. This is very well documented, but it is mostly a composite of several factors that are the mostly important thing, and a dysregulation of those cells that control the antigens and then tell the CD8 positive cells to attack beta cells, which should be regulated by specialized T cells. And here in type 1, there is an imbalance in this system. So to conclude, there is an increase in the incidence of type 1 diabetes, but also an increase of young patients with type 1. We can all see that in the emergency ward. And there is less and less genetic pressure, to say it very simply, and probably more and more implication of the environment, which is also true for the precocious puberty. So with that, I hope I keep the mind of the Marieke and Enrique.